Hi, and welcome back to Gastroenterology Land. I am so happy to see you again. Have you lost weight? You look terrific out there. When I see you again on the street someday after you've passed step 2, don't forget to say hello. I know that you'll have seen me, but sometimes I often can't remember having seen you, but please don't get offended by this. I do care for you anyway, and I send for you all the radiant goodness and beauty of the world through these videotapes and through Kaplan, from my soul unto yours, wherever you are sitting right now. Pancreatitis has hardly changed in the last 100 years. 100 years ago, it was caused by alcohol and by gallstones, and it's caused by alcohol and gallstones now. So pancreatitis is a disease that has virtually remained unchanged throughout the last 100 years. So you will not be asked about etiology, because whether it is gallstones or whether it is being punched in the stomach, it has not changed. Therefore, the presentation you will not be asked about. "Oi, does my stomach hurt? Oh, it hurts there. Oh, I don't feel like moving. Oh, that hurts, Daddy." Why? It hasn't changed. "I'm nauseous, I'm vomiting, I've got abdominal pain, I don't feel comfortable." This has not changed, and most likely you will not even be asked, because this is so obvious that it will be considered too easy to ask. Therefore, what you will be asked is questions about diagnostics and therapy. The questions are most likely to be about diagnostics and therapy because the other parts are considered to be too easy and too obvious. In other words, you got an alcoholic guy with gallstones, rarely with the use of medications such as pentamidine, because pentamidine is so rarely used intravenously because everybody's got a lot of T cells because of protease inhibitors, so rarely do you have enough people who are on pentamidine because HIV, once the T cells go up, you don't get pneumocystis anymore. 6-mercaptopurine and azathioprine for people who have inflammatory bowel disease as an etiology of that pancreatitis, and most other drugs such as sulfa, where essentially it is allergic in its reaction to the pancreas. I get a rash, I'm allergic to my skin. I get Stevens-Johnson and I'm allergic to my skin. I get drug-induced interstitial nephritis, I'm allergic to my kidney. It's the same thing. Sulfa, penicillins, allopurinol, phenytoin, rifampin. One day I'm allergic to my skin. One day I'm allergic to my red cells and I have drug-induced hemolysis. One day I'm allergic to my kidney tubules and I'm pissing eosinophils like there's no tomorrow. Eosinophiluria. I got uria with my eosinophils. The same process could happen as an etiology of drug-induced pancreatitis. Now I'm allergic to my pancreas. Before I was allergic to my skin or allergic to my red cells, and I had hemolysis and Stevens-Johnson. Etiology: pain, nausea, vomiting. In 1955, it was an elevated amylase and an elevated lipase. And in the year 2005, it's an elevated amylase and an elevated lipase. That hasn't changed. Now, what has changed? The answer is the CT scan. The CT scan changed the management of pancreatitis. The CT scan has changed the management because it has made our poor boy Ranson, who had such a smart idea. Ranson wanted to answer this question: who should I operate on? So Ranson's criteria were operative criteria because Ranson wanted to answer this question. Ranson wanted to answer the question, do I need surgery and debridement of my pancreas, or do I not need surgery? Because Ranson said, you know, most pancreatitis is mild and gets better. But when it's severe and necrotic, when that pancreatitis is severe and necrotic, when it's severe and necrotic, I need to get surgery. I need intraoperative debridement. So Ranson's fundamental question was this: who's getting cut today? So Ranson said, well, what I'm going to do is I'm going to see if you've got an increasing age, an increasing white count, an increasing glucose level because I'm not making insulin, an increasing white count. Am I becoming hypoxic because of ARDS? Am I having signs of hypocalcemia because my pancreas, she's a dead? And the dead pancreas, it is not making fat-absorbing enzymes. And when I don't make fat-absorbing enzymes, the fat is malabsorbed, goes into the bowel, the fat binds the calcium, and all of a sudden it's in my poo-poo, and I have had stool with my calcium in it instead of me with my calcium in me. The calcium's gone on it in stool, where it has made saponification, which the rest of the world calls soap, saponification, saponifying my calcium with the fats instead of being absorbed into me. Ranson's concept of looking at cell breakdown by elevated LDH and elevated transaminases was a concept designed to say this: who is sick, who's not sick? Who needs to be debrided, who doesn't need to be debrided? And how am I gonna know? Now, if I asked you in a class, in a live class, what's the point to Ranson's criteria? I feel like Julia Child here at this table. Educational desserts. So, if I asked you in class what the point of Ranson's criteria was, you would say, mortality, prognosis, who lives and who dies. And that's correct. But what's the point? To document the abattoir? To document simply who will die? What will I do based on the results of this test? What is the action that I will take differently? What is the action that I will take differently? Ranson's criteria do give an indication of prognosis and severity. But the major point about Ranson's criteria has been replaced with the concept of the CT scan. The CAT scan has replaced Ranson's criteria as the major determinant of whether or not to do surgery. If the CT scan shows severe necrosis, I have to do two things. Severe necrosis means I make a therapeutic change. One is I give antibiotics. And the best studied of those antibiotics is imipenem. The best studies of those antibiotics is imipenem. Number two, I should biopsy. I give antibiotics and I biopsy. And I biopsy because if I have infected necrotic pancreatitis, infected, as in bacteria, as in buggies in my pancreas? Why, yes. Severe is defined as what? Severe as defined as greater than 30% necrosis. I have greater than 30% necrosis. Hey, you got to get antibiotics. And I get antibiotics because severe necrotic pancreatitis is a terrific culture medium. A little bit of bacteria get in there and they grow. So therefore, I'm giving the antibiotics because of the extraordinarily high likelihood that severe necrotic pancreatitis will become infected. And the antibiotics do what is our favorite thing besides describing and expressing the thousands of unlimited ways to express love in this universe. And our favorite medical thing besides that is to lower mortality. What's that? Can you hear through the headset? Lower mortality, lower morality? Well, occasionally. But lowering mortality, our favorite medical thing to do. One, what are you going to do today after you finish listening to the videotapes? Why, I am going to find a new way of the 100,000 different ways to express love in this universe. Second, I'm going to learn about all of the things that lower mortality. Imipenem in acute pancreatitis. Who should be debrided? I biopsy and I find infected pancreatitis, and I debride. Ranson's criteria do give an indication for surgery. But you know what Ranson really wanted? He wanted a CAT scan, but he didn't have one. So this is the major point about pancreatitis. Gallstones and alcohol are accounting for 85 to 95% of all cases 50 years ago, and gallstones and pancreatitis still count for 85 to 95% of cases still. Trauma, mumps, hypertriglyceridemia, still causing pancreatitis. The medications, two things, pentamidine, 6-mercaptopurine azathioprine. However, remember that pancreatitis can be done on an allergic basis, caused on an allergic basis, the same way you could have a rash on an allergic basis, drug-induced hemolysis on an allergic basis, allergic interstitial nephritis on an allergic basis. All of them can happen from largely the same drugs. Sulfa drugs, quinidine, allopurinol, rifampin, phenytoin, lamotrigine, or as you might call it, lamotrigine. Lamotrigine. All the drugs do the same things. They're not going to ask you what the best initial test is because amylase and lipase are still the tests. And doing abdominal x-rays to look for quote-unquote sentinel loops is like me going outside today and seeing if I could find a black and white television, which is basically saying that I think it's 1968 or there is no CAT scan or no invention of a color television. Abdominal x-rays and sentinel loops are part of the archaeologic past. Abdominal x-rays are really only good for one thing. They are good to exclude obstruction. That is the major utility of the abdominal x-ray. Therefore, why am I telling you, hey, Conrad, why are you telling us about abdominal x-ray if it's not that good? If you're making fun of and in your amazing arrogance, ridiculing and looking down on the poor sentinel loop, why are you telling us? Just omit it. Well, I'm telling you because the difference between board preparation and ordinary learning is that board preparation, it's just as important to learn the wrong answer as much as it is to learn the right answer. Which of the following is the most accurate diagnostic test in determining the severity of the pancreatitis? Which of the following is most likely to determine the severity of pancreatitis? Which of the following is most accurate in diagnosing the pancreatitis? Which of the following is most useful to determine the management? Abdominal x-ray will be the wrong answer in the choices. For ordinary pancreatitis with no surgery, the point was to bowel rest, nil per os, as it says in the Latin NPO, nil, nothing, nihilos, nothingness, nil per os, nothing orally, intravenous fluids because we don't want them to dry out and become like a salty pretzel, and routine antibiotics do not help. They do not help. They're not going to help. Routine antibiotics, no. With severe necrotic pancreatitis, yes, they help. Why do I use the CT scan? 1, it tells me who to give antibiotics. 2, it tells me who to debride because of the needle biopsy. I give antibiotics and I biopsy. If the biopsy shows infection, I debride. Thank you very, very much.